Hello, good morning, all. Can you hear me? If you can hear me, can you just wave your hands? Let me be sure I can be heard. All right, thank you very much, and welcome to today's early eco session. My name is Prosper Onyekafiku. Working with me, my colleagues, I have Joy Chukwemeka, I have Miriam Olawale, and then I have Dr. Naji Azuka, all connected. And we are bringing today's session here from Factory Office in Abuja. Today, we'll be looking at a very interesting one on facility case presentation, and I hope we are going to learn from each other today, particularly learning from a facility in terms of effective management of different cases. So we'll be looking at one today. And we have our renowned subject matter experts who will be serving as a panelist today. And we have that the person is Professor Madu, and as well as a pathologist and associate professor of hematology at University of Nigeria and Nsukka, who will be providing further perspective after we are done with the facility case presentation. We also have other persons. I think I have Samuel Uraba from IHPN, who is also part of the team, on this, that will, if they have one or two things to add, they will go ahead and add. And today we'll be looking at diagnosis and management of genital warts in people living with HIV and AIDS. And we have a facility presenting that. That's Aqua Puma Primary Health Care in Imo State. But we have a state clinical mentor who will be making presentation in the person of Dr. Tobe Njoku, who will be, presenting to us shortly. But before I move on to usher him in, I want to call on the Federal Ministry of Health to give an opening remark. And standing by to do that, we have Mrs. Mayake Lami, who is a statistician and from the NASCAP division of Federal Ministry of Health. Mrs. Mayake, please, if you are there, can we have you go ahead with an opening remark? Mrs. Mayake, please, can you go ahead with an opening remark?
Yes, Mr. Proper, good morning.
Good morning.
Hello, good morning.
I can hear you.
Can you hear me? Okay.
Good morning, ma.
Good morning, everybody. You are welcome once again to another Spice Eco section on what the topic he has really mentioned from facility-based area. The topic is diagnosis and management of genital warts in people living with HIV. On behalf of the national coordinator, the Dr. Akudo Okpazu, and head of strategic information, Dr. Adebo Bolabashon, I hereby declare the section open for another impact knowledge to boost and improve more health service delivery to our people in that problem. Let us welcome the person that is going to present this topic, Dr. Tobe Njoku, and welcome the team that is going to add more impact knowledge at the end of the section. We appreciate all the IPs and facility-based staff that are here present. Let's commence the presentation. Over to you, Mr. Prosper.
Thank you very much, Mrs. Mayake, and thank you to Federal Ministry of Health, NASCAP in particular, for all your support. We also want to call on CDC Nigeria. We have someone to give a goodwill message, and standing by to do that, we have Dr. Chidozie Meribe. Dr. Chidozie Meribe is a senior program specialist for HTS. Chidozie, please, can we have you go on with a goodwill message from CDC?
Right. Sorry, I was muted earlier. That's why, I had that short delay. But again, good morning, Prosper. Good morning, everyone. I want to appreciate everyone for joining this meeting on behalf of CDC Country Director. We want to welcome all of you to this very important clinical meeting where we'll be looking at the diagnosis and management of genital warts in people who are living with the virus, HIV. We're excited usually to be part of this very meeting, webinar, where we continuously get informed about how management of HIV from the different perspectives and different stages of the management, from testing to initiation into treatment, retention, and all that has to do with it. So we're usually excited when we gather to hear more, especially from the field like we have today. So Akwakuma PAC experience from there will be shared by no less a person than the obstetrician and gynecologist that is working and supporting that very program. And I understand we have a professor, an erudite professor, who will also be providing additional perspective. This is really exciting. So I want us to sit back and, pick up new knowledge and new experiences coming from the field. Well done, everybody, and thank you.
Thank you very much, Dr. Chidozie. Also, a huge thank you to CDC for always supporting and providing guidance on this platform. Again, we want to ask all the facilities on the call to please turn on your video. We actually track this from the back end of our Zoom here. We want to see you, want to be sure that we are seated there, especially all the facilities that are seated in a didactic session to learn. Please, we do ask that you turn on your video. And then during question and answers, you could just use the Zoom platform to raise your hands and we will call on you, or better still, send in your concern through the chat box, and then we'll also give you the privilege to ask. Thank you very much for joining. So I'm calling on the presenter today. That's from Primary Health Care, Akwa Puma in Imo State. Dr. Tobechi Njoku, who is a state clinical mentor, that will be presenting today on the topic diagnosis and management of genital warts in people living with HIV and AIDS. Dr. Tobe, please, you may want to share your screen now and go on with your presentation. Dr. Tobe, are you there? Dr. Tobe, can you hear me? Dr. Tobe, if you are speaking, I think you are muted. You may need to unmute yourself. I'm talking to myself. Can you hear me, Dr. Tobechi?
I think he's trying to share.
Yes. I don't know if you can hear me.
Yeah, please, can you speak a little bit louder and let your camera be on? Also put the presentation on a slide mode.
Okay. So can you see me and hear me clearly?
Okay, I can hear you clearly. Yeah, I can hear you clearly.
Okay, thank you very much for introduction, Prosper, and good morning to everybody. It's my utmost pleasure to be here to make this presentation this morning from our Akwa Health Center on behalf of Caritas, Imo State. So if I have your permission to go ahead, can I?
Please go ahead.
All right, so the topic is clinical case presentation on the diagnosis and management of genital warts in a person living with HIV. So what we have here today is patient PO, who is a 22-year-old young female whose highest level of education is secondary school, and she's a petty seamstress. Matter of fact, part of the job she does is supported by the OTZ. Unfortunately, she's orphaned as both parents died from HIV and AIDS. She came in through the inpatient, the facility about 9 years ago. That's on 12th of March, 2014. She was age 14 as at the time. There was no prior ART exposure before this time. So her ART was commenced immediately after a positive HIV confirmatory test. And the initial adherence counseling was done the same day. She was found to be clinical stage 1 as at the time of diagnosis. And currently she's on tenofovir, lamivudine, and dolutegravir. And this is her 9th year on ART, like I said before. Because of her age, she was enrolled into the OTZ program, which, by the way, have provided a lot of support to her since then. She's up to date with her viral load, as the last viral load done was in October of last year, and it was detectable. So, as at the time we saw her last year, she had presented with genital rashes of nearly 1 year duration. Her rashes were nodular and distributed around the vulva. By the vulva, I mean around the genitals. And they later began to spread to the inner thigh and the areas around the pubic area, and in fact, also on the lower abdomen. All this happened rapidly within a 6-month period. The rashes were painful and itchy occasionally. However, there was no vaginal discharge and there was no ulceration. There was no bleeding from there. She didn't also have blood in her urine, neither did she have any vaginal discharge. The symptoms progressed rapidly and it was pretty ugly and unsightly, and impacted negatively on her psychosocial well-being, necessitating her to present to the facility. She had presented somewhere else where treatment was started prior to coming to our facility. Before this time, she was sexually active. She was sexually active to a PLHIV who had no complaints on treatment too. So the initial treatment she had before she presented to us was a topical application. That's a cream called 5% imiprimod, or otherwise called Adara. She was also given oral antibiotics, which, by the way, wasn't helpful as it were. We will understand later why antibiotics wasn't going to work. Of course, in our environment, most people who have a rash are likely to be given antibiotics, even when it's even when the cause is from a viral agent. So all the treatment she had wasn't helping, and then it was difficult for her to even procure the Adara. As some of you may know, it's quite an expensive medication. So OTZ was able to help her to get the medication, which I would say she didn't use it quite well. And at the same time, she actually wasn't very patient enough on using that medication before she presented to us. So there was no disruption of her menstrual cycle. She had not done a pap smear or any form of cervical cancer screening, including HPV testing. She had not gotten HPV vaccination, that is human papillomavirus vaccination. There was no history of smoking or alcohol before this time. So quickly, she had to be examined, and obviously she was anxious, considering the level of rashes she had on her genitals and her lower body. She was anxious with low self-esteem, and she wasn't pale. She wasn't having fever, and the rashes were obvious. I mean, there were no rashes, macular rashes on all limbs, and there was no bumps all over the body. That's lymphadenopathy. She weighed 50 kilograms and had a height of 1.58 meters. Looking at the genitals, I could see then we saw a diffuse, multiple skin-colored, cauliflower-shaped lesions scattered all over the vulva, the perianal skin, the mons, the inner thigh, and the lower abdomen. Some of them were fused with each other, and they were measuring between 0.5 centimeters to 6 centimeters in their widest diameter. I tried to put up a picture we had, with permission from her. We're able to get a picture, which is not very clear here, but this is like the lady sitting down or lying on her back and staying in a position as if to push a baby out. So it's not very clear, but you can see, you can see some bumps. You can see some bumps. If I could bring up my pointer here, you see bumps. Sorry. Okay, let me just try and. All right. So if you look around here, you see some bumps everywhere. This is like her thigh, inner thigh. This area here is area around the vulva. So it's not a wonderful picture, but please bear with us. Maybe I could share a better picture before or by the end of this presentation. So that's what we had, having done a general exam and then looked at the story, and it was obvious it got to a point of thinking and wondering what the problems are. Without taking our time, I would say the problems were obvious. She had no money. She was a petty seamstress and was struggling to get her medication. She had been given support by the OTZ, and the outcome wasn't wonderful. So we made a diagnosis of genital warts in a lady living with HIV. All right, so we have to talk to her about it. I and the ancillary staff, the ART nurse, and assistants, we tried to counsel her together. And the options of management was discussed, including ablative procedures. I will explain that in a bit. So the patient, while using other, accepted this time around to use something different, which was to use 0.5% podophyllin cream also, to be applied twice a day for 3 consecutive days with a 4-day break, and then repeat the same again every week for the next maximum of 16 weeks. We were to review after 1 month, and I can tell you that after 1 month, I wasn't surprised anyway that the outcome wasn't fantastic after 1 month. That is considering the level of spread of the lesion on her body. I didn't expect, that it would clear within 4 weeks. I would also tell you later that I actually also reviewed her yesterday again, and she still has, some, worries to talk about. So currently, as at yesterday, the smaller lesions had been taken care of, they had disappeared, but then some of the big ones are still there, and I'll explain why also. So that is, in a summary, what we saw on our examination findings, and then up to date of what we have on the patient. I don't know if I have the permission to go ahead and talk about, the literature to explain this a little more. I'm sure this might not be too, it may not be too obvious, to some people. Some people may really want an insight to understand what we're talking about a bit more. So Prosper, you tell me if I go ahead or if I should hold.
Please go ahead.
Awesome. Okay, fine. So as an overview, one of the most common sexually transmitted infection is also known as condyloma acuminata, and that is what we're talking about here, genital warts. Many don't know that that is the commonest sexually transmitted infection globally. And where the burden of HIV is high, it's also a problem in Africa, in the sub-Saharan Africa, where HIV burden is high. So we expect that because of the close relationship between HIV and human papilloma virus, the virus that causes genital wart, they are quite close, that where you have a high burden of HIV, you're likely to have genital warts. So they're like raised, smooth, or rough, pale, or skin-colored growths appearing on the genitals, usually with a broad base. Incidentally, it doesn't just only appear in the genitals. It can also appear in the mouth or in the throat, especially depending on the sexual behavior of the persons involved. That means people who do oral sex can actually be at risk of having it in the mouth or in the throat. By the way, I must say also, surgeons and physicians who treat this situation using diatomy, burning off the lesion, can actually have it inhaled. They can inhale the smoke, and they can also have it in their throat and in their mouth. So like I said, it's one of the commonest. Some literature will tell you nearly everybody who is sexually active at one point in time or the other will have human papilloma virus. Not necessarily warts, but they could have human papilloma virus, which is the virus that causes genital warts. Like I said, it's caused by human papilloma virus. The serotypes of interest are HPV 6 and 11, even though there are many more, numbering nearly 40. So this human papilloma virus 6 and 11 are actually the low risk type. So they rarely cause cancer, as it were. The risk factors can be easily deduced from people who have multiple sexual partners, risky sexual behaviors, unprotected sex, people who are immunocompromised, like we have in this lady who is HIV positive, and people who smoke. Of course, smoking has a relationship with the lowered immunity, as well as people who use oral contraceptive pills. But I will tell you that using oral contraceptive pill alone is not a risk factor per se for contracting HPV. However, a lot of people who use oral contraceptive pill as contraceptive may not use barrier method. So because they don't use barrier method, they're actually at risk of skin-to-skin contact, and then risk of HPV is high. So to keep things moving, it has a long incubation period. So sometimes diagnosis is difficult. I mean, you can't trace it. You can't say what time did this happen? When did I get this? So you see, 1 to 20 months, someone gets contact with someone who has HPV. It could take as high as nearly 2 years before the first lesions appear. So you can see that, that gives cause for concern. It can go on its own, by the way. People who have competent immunity, who contract HPV, can actually have it sorted out by their immunity within 2 years. You can also recur, especially when not treated, or when it occurs in people like the index patient. Like I said before, this disease can be contracted, yet the virus can be contracted without somebody having symptoms. And by the way also, it can also be transmitted by the person that has the virus without symptoms, can transmit the virus to someone else who may eventually develop symptoms. So it appears unsightly as it was in our index patient. It was terrible. It wasn't looking nice. She was worried. It took a lot, get her to get a consent to get examined. And it can actually be annoying and embarrassing. So in the context of HIV, which is the reason why we are here, what happens? I mean, HPV is there in the general population. Genital warts is there in the general population. But what about, this subpopulation of people who have HIV? The prevalence has reduced actually since the introduction of antiretroviral therapy. Nevertheless, it runs a more progressive and severe course. Like we had in this lady, it was all over the inner thigh, all over the inner thigh, all over the vulva, all over the mons, all over the lower abdomen. So it was a widespread lesion she had. It can also reoccur even after treatment, especially in the index patient we have. It occurs on unusual sites for people who have HIV. There's a higher risk of malignant transformation. Probably the pathologist may give an insight to this later on. And that is why if you are treating someone who has HIV, who has genital warts, there may be need to take a biopsy from the lesions. I don't know if I'm still being heard here. Am I still being heard?
Yes, we can hear you.
Yes.
All right, so there's a high risk of malignant transformation, but that means it could develop to cancer. And that is why if one is treating with cream entirely for someone who has HIV, that may not be the best. So some may be chopped off, but that means some may be cut off and sent for histopathology to determine, whether there is high-risk dysplasia. And that can actually happen in 18 to 56% of these persons. All right, so why are we worried? HPV and HIV increase the risk of acquisition of each other. If someone has HIV, there's a high risk of getting human papillomavirus and warts just because the immunity is lower from HIV. Someone has HPV and, for instance, has genital warts. Genital warts can bleed easily, they bruise quite easily. Once you touch them, just sponging, cleaning yourself during a bath or a shower can actually make them bleed. The physical contact that happens during sex can actually make it bleed. So imagine someone who has the warts and has no HIV, and then is having sexual contact and bleeding comes. Without bleeding, then the secretions from the body of the person that has HIV can be transmitted through there. So it may be more difficult and expensive to treat if it appears along a wide surface area, for example, as it's happening in these our patients. I put this in red to just bring to the fore that it's been a bit difficult to treat this patient. So to what extent can OTC help? That's the question here. Like I said earlier, they've been helpful, they've been wonderful, and a lot more needs to be done nevertheless. There's need to carry out Pap screening, that Pap smear screening for cervical cancer. There's a close relationship between cervical cancer and human papillomavirus. However, the serotypes of the virus that cause the two are quite different. Genital warts, I've said, can bruise easily, and they are more difficult to treat in the context of HIV. So we're gradually coming close to the end of this discussion, but if you may just give me a few more minutes, how do you identify diagnosis, which is what happens at the facilities? Some of the facilities, unfortunately, do not have doctors there, but it's something, some healthcare workers can actually identify. Even the nurses can identify it. So usually inspection, looking at it, having a look at it can actually tell you this is what it is. Many times you don't need to actually do any biopsy or do histology. However, the history of exposure may not be clear. This person may have had this contact 18 months ago, 10 months ago, and the manifestation is coming today. So it's difficult to trace, really. So contact tracing can be difficult for human papillomavirus, pretty much unlike in HIV. So there are things that look alike, that look like it. So it doesn't mean that when someone has a skin eruption on the genitals, it automatically means the person has genital warts or has HPV. So we could see things like scabies, skin tags, molluscum contagiosum, and a whole lot of things. Yeah, so that is it. But then when there is confusion, there may be need to take a piece of them, some of them, and send it for histology. I reiterate again, the people who have HIV, it may be necessary to take some biopsy just to look at chance of malignant transformation. All right, so in terms of management and treatment of this patient, it depends on how they present. I mean, someone may present with genital warts and is not sexually active, and the lesion is very small. I'm not bothered about giving the infection to anybody. In that situation, the person can actually, with competent immunity, he can actually go on his own. So that's why you have expectant management. You look at it, okay, what happens next? Let's just have a look and see what happens next couple of months to 1 or 2 years. It could go on its own. But we could use medications to treat it. So some of those medications include podophylotoxin, podophyllum that was used on this patient, trichloroacetic acid, which, by the way, TCC is used for patients who have what we call internal warts. You may not be able to see internal warts on the skin, but it could be right there in the vagina, or it could be right there in the throat. So some of these medications you use to treat external warts, you can't put them inside the throat, and you can also put them inside the vagina because it just definitely burn the vagina. So other options are 5-fluorouracil, imiquimod. Imiquimod was what was used for her the first time, but we didn't get results. We now move from imiquimod to, incidentally, it's like going back to podophyllum. One would expect that imiquimod may give you better results, but because she's HIV positive, because of the issues around her, because of the widespread nature of the ailment, I'm not too surprised, even though we hope to do more to get her better. Cinecatechins, interferons are the options. So, but like I said, you may need to take biopsy sometimes. So that brings us to surgery. That brings us to using nitrogen to, cold coagulation to get it off. We could use laser. Now talking about laser, when it's widespread and you don't want to use, let's say, a wide surface area involved, the drugs we're using, those medications, those creams are cytotoxic. If used in a widespread area, there's a chance we could cause toxicity using those drugs for the patient. So I thought of laser for this patient, and it's good we're discussing this today. Maybe when other people make their input, to be able to know, can we use laser? Is this available for this very poor girl who is actually still in need as at the time we saw her yesterday? We can use electricity to burn it off, but actually cut it off with knife and send it for histology. So I'm coming to the end of this. So, but what can we do to prevent this seemingly very common situation that can actually be very nagging? So counseling is very important. Safe sex, counseling on safe sex, using of condoms. I put a question mark here on using condoms because condom in itself is not entirely protective. Let me give you an example. Someone makes contact with this particular person in question and is wearing a condom. The condom will not protect your body from touching the other parts of our body that have the lesion. So it could be on the thigh, it could be on the lower tummy. So condom does not really do the entire job, even though it helps. What about human papilloma vaccine? Human papilloma virus vaccination. And that's the big question here. I would say gladly, federal government announced 3 weeks ago that they brought in human papilloma vaccine, human HPV vaccine in the country. But we would like to know its availability, especially for this special population. So the question is, can the program make it available to high-risk persons living with HIV, the key population? And with key population, we know, a whole lot is involved. So HPV vaccination will go a long way in trying to reduce the occurrence of genital warts. So it can be given to boys and girls from 9 to 26 years. And for people who are above 26, there's home hope. You can meet your physician and then they will tell you how your dosing will be portioned. Now, the question is, this girl has what? Can she still get the vaccine? Typically, vaccines are supposed to be preventive. You want to give it before exposure. But we all know that it's not always so. For example, in the era of COVID, people have COVID and still get the vaccination. So experts are saying, yeah, someone who has HPV infection and warts can still benefit from having the vaccination. In conclusion, I want to say genital warts is caused by low-risk human papilloma virus, 6 and 11 serotypes, unlike cervical cancer, which is caused by high-risk oncogenic types, 16, 18, and the whole lot. It is the commonest sexually transmitted infection globally. That's a firm hand grip or handshake between HPV and HIV. So they're like, Siamese twins, if not properly, talked about. Adherence to ART and healthy sexual behavior is preventive. Human papilloma virus vaccination is everything here. It is treatable, but it's challenging as we have in this case. Thank you very much for your attention, and I hope I didn't take so much of your time.
Thank you very much, Dr. Kibechi, for the wonderful, detailed, and stay concise You may want to stop sharing your screen now. All right, thank you very much, and it's nice to be back to the big. So, do we have? Of course, I know we'll have questions, but before we begin to take questions, I want us to further step up the discussion. We have Professor Madwan Azeze, who is a pathologist and also an associate professor of hematology at University of Nigeria, Nsukka, who would want to provide further perspective and guidance concerning the presentation in view of how the patient was managed, and then talk around other aspects of the management of genital warts in persons living with HIV. Professor Madu, please, can we have you, please?
Thank you very much, Prosper, and thank you, Dr. Njoko and Kwakuma Health Center. Just a few, he has actually made my job very easy. Can you hear me?
Yes, we can hear you.
Okay, thank you. He has actually made my job very easy. So I'll just pick some learning points and some points to dwell on just a bit before we go on to take the questions. Number one is that you have to know that in the background of HIV, presentation of STIs may vary. Like they may become more systemic or more aggressive. So the attending physician or attending nurses or CHU in your health center, please be aware that the typical presentations that you see may not be what you will see in the background of a HIV patient. Like in most cases, genital warts appear as just a few lesions, like 3 or 4 in the perineal area around the vulva. But in this patient, you can see it has become quite extensive. The second thing is that in the background of immunosuppression, the frequency of complications also increase. I think Dr. Tobechi also mentioned it. The probability of going on to have a cancer and dysplasias occurring also increases, okay? Also, the frequency of drug resistance and drugs not working effectively also increases, okay? Because of maybe the mutations that have occurred in the viruses or in the bacteria of any other STI that you're treating. Putting that in context, you have to be aware of the fact that the drugs may not easily work as you think they were going to work, just as we're seeing in this case. Then this brings us to what we have always been pointing out in our previous sessions, STIs and HIV. There's need for early diagnosis and treatment of STIs, both in people that are seropositive or seronegative, both in people that are HIV positive or negative. There's need for quick and urgent diagnosis and treatment because, as he mentioned, HIV and STIs have a good handshake for both of them, okay? One increases the predisposition to getting the other. And it's very, very important that we put this in context. Also, remember, I don't know if it was mentioned in this scenario, for STIs, you must treat both partners. I don't know whether Akuma Health Center has managed to track the partner of this young lady because he may not be showing symptoms, but he may also be having the disease as we go on. So he may be an innocent carrier for now, but he's also a threat to other people. So we should, in treatment of STIs, always remember to track and treat both partners. Then also the need for keep counseling people, the need for safe sex. The need for safe sex and possibly abstinence, because just as it's mentioned, HPV is one virus that you cannot prevent based on condoms. Okay, just any contact within the perineal area or any intimate contact with somebody that is infected can also get you infected. Vaccines will help even in people that are already positive. How vaccines help is that they try to stimulate our immune system to produce more antibodies and more immunocompetent cells. And in some malignancies and some cancers, as well as some bacterial infections or people already positive, you go ahead and vaccinate. It helps to actually fight the infections. Okay. Now, I don't know in this particular scenario of this girl that I think if podophyllin doesn't work, I will suggest that you also try apart from electrocautery for the lesions that you can use diatemy to cut off. we should also try immunizing her even as much as she's already positive. Okay, probably using a vaccine that does not contain a life attenuated version of the virus, if you get what I mean. So there are different forms of vaccines and there are different forms of HPV vaccines. Some of them are live vaccines, some of them are RNA, some of them are DNA. So I'll stop here, and I think by the time the discussion begins properly, and one more thing, I think with respect to the KP, I think it's important that we start seriously thinking of giving them HPV, because I don't think the vaccine is cheap. You have to pay for it. So I think for KPs, it's important that we may seriously consider giving them HPV vaccination. Thank you, and over.
Thank you very much, Prof, for that perspective. I don't know, okay, maybe if there are I have other SMEs on the call. I have Dr. Yetunde Akani. Please, if at any point you want to add or say something, please do indicate by raising your hands, and I will call you. Okay, let me call on Dr. Yetunde. Dr. Yetunde, please, can you unmute yourself and go on?
Yeah, good morning, everyone.
Good morning
special thanks to the presenter, Dr. Tobichi. That was a wonderful presentation. I'm not just sure, maybe I missed out some information, but I just wanted some social background to this patient, because looking at the age, still a young adult. And so I want to know, what does she do? Is she married? Is she single? Does she live with her parents? And so those are the basic information I also needed, because that will actually also help to facilitate the management of that patient.
All right, thank you very much. Dr. Yetunde is a counselor and also one of our subject matter experts. So some of these key questions is also going to help her, and provide ideas. So can I have Dr. Tobe, please just respond to this, and then we'll move on to other questions. Dr. Tobe, please, over to you.
Okay, so it's good to be back. The first was whether the partner was tracked and treated. That's what the professor asked. Yes, the partner is PLHIV and has no symptoms. But like I said, you're probably not going to treat someone who has HPV infection without any manifestation. I mean, it's not like, it's a common thing. Some people have the virus, but they don't have any manifestation. So in this case here, this particular partner has no complaints, but we are in talks and we intend to continue to do that. By the way, sometimes when someone has the infection, it doesn't mean it's from the current partner. It could be from a previous partner, which happened maybe 2 years ago, maybe 18 months ago, maybe 1 year ago. So on the social background, I mentioned that she's a petty seamstress. She makes clothes, in a petty, very hardly any capital. I mean, she's been supported by OTZ. She's an orphan. Both parents died of AIDS. She's not married, but she had kind of sexual relationship, even though that has been aborted by the current. So socially, I would say it's quite unfortunate for her. It's not been wonderful. She's been feeling like, okay, my boyfriend has left me because of what I'm going through, and that's not wonderful. So that's why I say she was of low self-esteem at the time we were examining her. So that's that, providing insight on social background. She's being supported by OTZ, considering her situation. I hope I'm able to answer some of those questions. Thank you very much.
Thank you very much for that. And Dr. Yetunde, I hope that helped. So we can entertain questions now, and both you can send on chat box, but I would want you to raise your hand, and then I will call you. So we have John Tunde Rimu. Your hand has been up. John, please, can you go on with your question?
All right, thank you very much, Dr. Tobichi, for the wonderful presentation. Just like you mentioned about the alliance between HIV and HPV, but luckily for us, with the advent of test and treat, probably we are not seeing as much of HPV infection that we used to see before. But this is just a general counsel for most of our HIV treatment centers. Most times for people that complain of STIs, we really want to investigate or examine them properly. So probably we will not be making this diagnosis very early. So I want to appeal that we try as much as possible to examine these people as properly as possible. This particular patient is in a PAC that most likely all your lines of management may not be possible in those areas. And they are capital intensive. So I also want to request that since almost all the partners are here and stakeholders, probably we'll start looking at a way of having a referral system for some of these diseases that are actually difficult to diagnose sometimes or are capital intensive to treat or need a form of special expertise to treat. And finally, I want to ask, what is your next line of management for these patients based on what we have on the ground now? Thank you very much, and I yield the mic.
All right, thank you very much, Dr. Aremu. So I would want to call Prof, or I want to call Prof to respond, or Prof, is it something you want to respond, or I should get back to Dr. Tobe Njoku? Prof, do you want to respond to this?
I don't know if Dr. Aremu asked a question or whether it was a comment. I think it was more or less a comment. But let me say that with respect to the case in hand, I think it's also important that we know when to escalate cases. For me, I think at this point, Dr. Njoku should seriously start thinking of referring this patient to either the Federal Medical Center in Owerri or a teaching hospital, where a dermatologist and people that can offer more basis of care should be able to look at the case. That's my take, because I know he's a consultant gynecologist, but I think when other specialties also join together to make their contributions, you may have a better outcome for the patient. So I think we should also, just like Dr. Aremu noted, know when to escalate. Once you treat and it's not working for STIs, just as we noted, please know when to escalate. Even if you have the necessary knowledge, many heads can also help to make our patients better. Thank you.
Thank you very much, Prof. We have more hands, and then I also want to encourage all the facilities on the call to please stay up yourself, and if you have any question related to STD, sexual and reproductive health, we have best hands on the call to provide perspective to that. It may not necessarily just be on the topic, but anything related to this sexually transmitted disease, we can always address it here. So we'll have Onyeni Christiana. Onyeni Christiana, I'm enabling you. Can you please unmute yourself and ask your question?
Good morning, everyone. Thank you, Mr. Prosper, for the opportunity to ask my question. Thanks to all the presenters. Can you hear me, please?
Yeah, I can hear you. Please go on. Okay.
Please, my question goes to Prof. He was talking about vaccination for this particular patient. I used to know, and the popular opinion is that once someone is sexually active and already has some features suggestive of HPV infection, the vaccines are not recommended for them. But I heard Prof saying that we should vaccinate them, HPV vaccination. Please, I would like Prof to throw more light on that aspect of vaccinating an individual that already has features suggestive of HPV infection. Thank you very much, Anova.
All right, thank you very much. Prof, do you want to throw more light on that? Hello, Prof, are you there?
Well, it's not general practice, please. That's why I said at this point, it may be better to manage at a tertiary level. But I know that, medicine is an art as well as a science. So there's a limit to what you can actually do as in this facility where you are. Number one is that if I know this patient's CD4 count, which is important with respect to response to vaccination, okay, you may decide in situations like this, where there is no other option clinically, you may decide to give a vaccine. If you're sure that the CD4 count is well and good enough to be able to mount a good immune response, it may actually help. But please, it is not for general use or for general practice. This is what the clinicians who are managing the patients, who have the capacity to take the decision, may decide to take. So it's not like it's general knowledge. Thank you.
Thank you very much, Prof, for that. We still have another question from Dr. Obatumi David Olayinka. Dr. David, please, can you unmute yourself and ask your question? Dr. Obatumi David.
Thank you, Mr. Prosper. Thank you, Chief Prosper. For me, it's a contribution. Year 2010, when I was doing my house job at University Teaching Hospital in Ilorin, we had a case that was reminiscent of what has been presented. And there was something we did. It was to take a biopsy. The presenter mentioned that the bleed, it is true. When we took the biopsy from the lesion, we ended up transfusing that lady like 5 or 6 pints of blood. Although we were prepared with 1, we ended up transfusing maybe 6 pints. And if you see the lesion we took, it was very small. However, because of the angiogenesis around that place, she bled in a way that even the experienced ones were not expecting her to. We were even querying whether she had some blood dyscrasia. So my point, just as the presenter said that they bleed, let anyone who is trying to take biopsy be aware of that and prepare in a setting where those people who are eligible or who wants it could be transfused easily. Thanks a lot.
All right, thank you very much. Sorry, Rosemary or Morige, I just saw your question on the comment. Can you please raise your hand and ask your question so that it can be addressed? Rosemary, please. Rosemary, can you raise your hand and ask your question, and then it will be addressed? All right, Rosemary, I've enabled you. Can you please unmute yourself and go ahead with your question?
Okay. Good morning to everyone.
Good morning.
Thank you very much for the presentation. Yeah, my question is, now that we know the incidence of HPV is on the increase, what can be done to protect partners to those clients, especially the one that was presented today? I believe she may have a partner or partners as the case may be. So in that case, we will need to do contact tracing, and then for prevention to other partners, what can be done? And also, since we know that the male partners are the healthier carriers of the HPV, in that context, what should be done to prevent the spread of the infection to their female partners? And then lastly, we're talking about key population. We know they are vulnerable to HPV. So in this context, what should be done in regards to key population to prevent them from?
Right. Thank you very much. Prof, do you want to help? Please, at any point in time that you want to respond to this, please just go on and speak, But let me.
Yes, Prosper, I would like to respond to a couple of things here, okay? Please, if you don't mind.
Said?
I'd like to respond to some of the comments and the questions, if you don't mind.
Please go ahead. That's why I'm calling you. Go ahead, please.
All right. So thank you, Rosemary. I was trying to, type a response to your question. I saw it there. Prevention is key. Like I said, primary prevention is utmost. So you talk about vaccination, like Prof has been, emphasizing. I emphasize on vaccine. That's why I'm happy I had an opportunity to present this today, where everybody's listening. Every stakeholder is listening. And HIV program cannot be complete in the absence of vaccination for HPV. And that's the fact. We have KPs, we have a lot of people at risk. We have the commercial sex workers, we have MSM, we have all of this. So we can't be complete without doing primary prevention. In Atlanta, in Europe, in Asia, the vaccine is given to boys, like you say, they are carriers at age of 9 to 13. The idea is to give it to them before sexual debut, both boys and girls. So if you give the vaccine before sexual debut, then you have probably done the primary prevention. But like Prof has been saying too, and like I said, the HPV can continue even outside these age ranges, outside even beyond 26 years of age. But you have to be careful when giving that against barring other exigencies, barring other factors, including the CD4 count, the level of immunity at that time. All right. So for the partner here, like I said, it's a bit difficult and challenging sometimes because the partner may not even have the partner may not have any manifestation initially, and you're not going to treat someone who doesn't have any manifestation. Okay. So for protecting the partner, you have to talk about abstinence at that time. You have to explain to the couple what the situation is at that time. Just like treating someone who has chlamydia, for example, the partner have to be counseled together. They have to understand that this is actually quite infective or infectious. So you don't want to have contact until treatment is completed. I've had a case where we used creams and eventually did a scission. And throughout that period of about 2 to 3 months, there was no sexual contact for the patient in question. So for that period, there should be abstinence until it is even feasible to use barrier method like condoms. If it's only when it's feasible to use condom that I can actually say go ahead and use the condom. So it can be challenging, but a lot can be done to protect the partner, the KPs, the MSM, and all of that. By the way, somebody talked about bleeding and incision. Yeah, that's true. Bleeding can occur, can be aggressive, and that's why the patient is told not to try to amputate it himself or herself. Some people go home and they feel like, oh, I want to chop this thing off. It's been there for years. It's been there for 5 years. I just want to cut it off. And then boom, you are getting transfused. Right. So you should be careful when you're excising it to reduce the so it must be done in the theater. If there must be an incision, it must be in a controlled environment like a theater setting. Next line of management, someone asks, what next do we do? Yes, collaboration, cross-referrals. Talks are ongoing with a lot of other specialties that are involved, including even a plastic surgeon who has said, we could do this, we could do that. People are looking at laser. So that's why I asked the question here, is laser available in the country? If it's available, then it would be fantastic if it's available, especially when you have a widespread lesion. If you're using cream all over that widespread surface area, you're also endangering the patient by toxicity from those medications. At the same time, you're not going to start cutting off everywhere. The person is going to have a lot of scars all over the thigh, all over the pubic area, and all of that, and the lower abdomen. So laser becomes a reasonable option, but it's subject to agreement and referrals. Remember, this girl doesn't have nothing. She has no money. Her business is practically, she's practically, feeding from hand to mouth and from the help of OTZ. So asking her to even get referred means also, empowering her financially or taking responsibility entirely to see that she gets the best care that she can get. Thank you very much, and over.
Thank you, Dr. Tobe, for that. I think I need to take one more question and then we'll wrap up. This is from State Clinical Mentor, Elizabeth Obioha. Elizabeth Obioha, can you quickly ask your question in 1 minute?
Hello, thank you so much, Prof. and Dr. Tobechi for the presentation. It was really impactful. Please, I want to understand.
Sorry,
Hello?
Elizabeth, you're a State Clinical Mentor, right?
Yes.
Do you mind turning on your video? Sorry if I'm asking.
Okay.
Yeah, and go on with your question, please.
All right.
Just go on with your question if you're unable to do that.
All right, sir. All right. Thank you. My name is Dr. Elizabeth Obioha, the LCT State Clinical Mentor. So, thank you, Prof. and Dr. Tobechi for this wonderful presentation. It was really impactful. Please, I want to understand, please, I know that the primary prevention method is vaccination. So I don't know, in his explanation, I don't understand why giving someone that has that is already infected with HPV vaccination as a form of treatment? And so, because you said that it's a general practice, I don't know why it is being practiced, because I know that once there is an infection, there is no need already for vaccination, since vaccination is the primary preventive method. I don't understand. I don't know why it is being practiced. That's what I'm still confused about it. Thank you.
Okay, no problem. Prof will
let me just quickly say it, please. I didn't say it's general practice. Please, you don't vaccinate anybody that is already infected. Leave it to the specialist to decide how they want to treat the patient. As a matter of fact, delete it that I ever said that you vaccinated anybody that is already infected. Just leave it up to the specialist or the consultant to take the decision. I said in some cases you may do that, but let's leave it for the purpose of our discussion here. You don't vaccinate somebody that's already infected. But remember that you don't test people for HPV before you vaccinate them. So how do you know who is infected and who is not infected in the people you're vaccinating? But let's leave it like that. You don't vaccinate anybody that is infected generally in immunization practice. I didn't say it's general practice. I said just leave it to the specialist to take the decision. Thank you.
All right, thank you very much for that. And then let me call finally Dr. Yetunde Akani. Dr. Yetunde, please, can we have you in 1 minute?
Okay, thank you very much. I just want to give a different perspective or just add to what is on ground. It's obvious that this patient is an indigent patient. And so whatever we want to do, we need to take note of the fact that they need to link her up to more social services that are available if the need be that she needs to be transferred. Because if that is not done, truly it's going to affect whatever management that this patient will be receiving. So it's very, very important that she gets good social support and then also be referred to social services that will be available wherever she will be referred to.
Thank you very much, Dr. Yetunde. And thank you, everyone. I think all your questions have been addressed. And in case if there are still some burning questions or concerns that you are able to ask, we want to encourage you to kindly send us a mail and then send us a mail and attach your question and we'll be able to respond to that. Thank you very much. At this point, I want to ask Dr. Chidozie, Dr. Tobe, do you have a final word before we wrap up? Dr. Tobechi.
Just to say I'm happy to, thank you very much, Prosper. I'm happy for the opportunity given here to, interface on, knowledge. But like the last speaker said, this patient is quite indigent and needs help. So our take home today is for the stakeholders, is there anything we can do further to help her in her quagmire? And then another thing again is the KPs, again, all these other guys, HPV vaccination, and I'm sure this is something we can all do if we put hands together and agree to get HPV vaccination. It's not just a problem for the HIV patient, it's also a problem globally. Remember, cervical cancer is there, and every woman who is sexually active is at risk of having cervical cancer. Human papillomavirus is responsible for genital warts. Some other serotypes of the same virus is responsible for cervical cancer. HPV vaccination is like a one-shot plug, I would say, to preventing up to 90% of the cervical cancers. So we should, let it be food for thought for all of us to see how we can collaborate and see how this vaccine can be available. Thank you very much for your time and your attention.
Thank you very much. And over to you, Prof. What will be the final word, please?
Thank you very much for listening. Let's take away the learning points that just look out for these signs in your patients. Ask questions, early treatment, very important, and always counseling is key. Safe sex or abstinence, depending on whichever one can practice. Thank you.
Thank you very much, Prof, for that. Then I want to call on CDC for the final words. I don't know if Dr. Chidozie is still on the call. Chidozie, if you are still on the call, can we have a final word from you or John Essien? John Essien, are you there? All right, let's move on to Federal Ministry of Health for a closing remark. Mrs. Mayaki Lami, please, can we have you give a closing remark? Mrs. Mayaki, are you there? Mrs. Mayaki or any representative from Federal Ministry of Health? All right, thank you very much. I think Mrs. Mayaki is head up in another meeting. So all of us here at PLHIV, I, myself, my colleagues that are on the call, want to say thank you very much for joining us in today's tele-eco session. We'll look forward to next week after election for yet another wonderful one. And we also want to encourage you to please go out there and vote right, vote your conscience, vote the right candidate. Don't sit back at home. This is the time for us to do the right thing and exercise our civic duty and franchise. Please go ahead and vote. We want to encourage you so that we can have a better country to live for ourselves and for our children. Thank you very much and do have a great day. See you again next week and bye for now.